Good morning, everyone. My name is Chris Haney. I'm the Executive Director of the California Budget and Policy Center. Thank you for joining us this morning for our webinar, Children's Health in California, How Can State Policies Help Promote a Lifetime of Health and Well-Being? It's my pleasure to introduce the panelists for today's webinar. Kristin Schumacher, a policy analyst here at the Budget Center, who led the research on the reports that were shared with you as part of today's webinar. Scott Graves, our Director of Research. Edward Schor, the Senior Vice President for Programs and Partnerships at the Lucile Packard Foundation for Children's Health. And Timothy Brown, the Associate Professor of Health Economics at the University of California, Berkeley School of Public Health. And I'm very glad to have all of these folks with us today on this webinar. The work that we did here at the Budget Center that we'll be presenting and sharing with you all today was made possible by the Lucile Packard Foundation for Children's Health. So I'm going to turn it over to Edward Schor now to give a few remarks to start us off.
Thank you, Chris. The Lucile Packard Foundation for Children's Health has its mission of improving the health of children in California by raising the visibility of their health issues and by improving the systems of care that serve them, especially the systems that serve the most fragile children, those with complex and chronic health problems. My own experience in state government suggested to me that achieving the best outcomes for the state's residents can sometimes be hampered when departments and units within them plan and operate independently in silos. The state government can potentially act as a shared foundation on which coordinated planning and operations can occur. Unfortunately, this rarely happens, in part because the budget is not examined in its entirety. We funded this project, a consolidated look at the budgets of all of the publicly funded child health programs in California, with the hope that having all of that information in one place might facilitate coordination of programs in the future.
Thank you, Ed. We really appreciate it. And so now we're going to get started with the presentations by the panelists. A couple of notes quickly about the flow. We're going to start with Kristin Schumacher, who will share the highlights and findings from our new special report. That will be followed by Scott Graves, who will provide a quick budget update on where the current deliberations are around children's health programs. We'll then turn it back to Ed for some comments on programs and policies for children with special health care needs in California, followed by Professor Brown, who will then talk about public health spending at the local level and how it relates to investing in public health in California, the role of state investment, and key opportunities for policymakers at the federal, state, and local levels. And then we'll turn to a question and discussion period that we'll facilitate with all of you. And a couple of quick notes in terms of housekeeping. You can ask questions, for those of you out there listening, by typing your questions into the box at the bottom of your control panel. The questions will be received here and funneled to me so that I can ask them of the panelists. Please submit questions as we go throughout the panelist presentations here, and we'll log those and make sure that we get to as many of them as possible during the question and answer period at the end. And one final webinar housekeeping note that we will be recording this session, and the slides and materials and the recording itself will be posted later today on our website at calbudgetcenter.org. So that does it for the housekeeping parts. I'm going to turn it over now to Kristin Schumacher, policy analyst here at the Budget Center, to talk about the findings and highlights of the work that she led. Kristin?
So the question we addressed in our new report, Children's Health Programs in California, is why should we care about programs and services that support children's health? We know that good health in childhood means a better shot at good health in adulthood. This results in reduced costs for families in the state and a more productive workforce too. We also know that poverty is a threat to children's health. Children in low-income families are more likely to be in poor health. They're more likely to grow up and have poor health as adults, and their kids are also likely to have poor health too. This creates an intergenerational cycle of poverty and poor health. The good news is that public policies and programs can help to mitigate the effects of poverty and help to improve children's health too. So public health care coverage, such as Medi-Cal, which is California's Medicaid program, can increase children's access to medical care. And then public health services like vaccinations or home visiting programs and dental screenings can improve health. They can teach children healthy behaviors, and they can even address health disparities amongst children as well. So the purpose of this report was to identify programs and services in California that support children's health, and then to go a step further and look at how investment in these programs has shifted since the beginning of the Great Recession. In order to manage just the sheer size and scope of the project, we limited health pretty narrowly to children's physical health, including programs and services for pregnant women, and then we focused on programs within the Department of Healthcare Services, or DHCS, and then the California Department of Public Health, or DPH. Within DHCS, we've included programs that were transferred from Mr. MIB to DHCS in recent years, such as Healthy Families and Access for Infants and Mothers, or AIM-2. And then finally, we used spending and demographic data for 2007-08 fiscal year as our pre-recession baseline as compared to 12-13, which was the most recent data available when we started this project. So with these parameters in mind, we identified 12 programs within DHCS and 21 programs within DPH that focus on children's health. And these programs range dramatically in size and scope. Within DHCS, the largest program is the Medi-Cal program. Medi-Cal provides public health care coverage to over half of the children in California. In the 12-13 fiscal year, this was 4.5 million kids. In addition, the Healthy Families program, formerly California's CHIP program, served over 600,000 kids during that same fiscal year. On the other hand, there are some smaller programs within the Department of Public Health and DHCS that serve a very targeted narrow group of individuals, such as the California Home Visiting Program, which supported about 2,000 infants and their families in 12-13. And then another example of the smaller program is Black Infant Health, which served about 6,000 pregnant women in 12-13 with just federal dollars at that time. In the companion piece to our main report, we created a timeline of many of the budget and policy changes that had an effect on children's health programs. And we looked at from about 2007 through 2014. It's important to note that in the time period from 2007 to 2014, there were many changes made to these programs, and not all of them were bad. For example, some of the bad changes that happened as a result of the Great Recession included things like cuts to benefits to the Healthy Families program, reduced Medi-Cal provider payment rates, and then general fund cuts for programs that support pregnant women and children in the Department of Public Health. However, this time period also included federal health care reform, where we saw a huge expansion and protection of children's health benefits and the launch of Covered California, which is the state health insurance exchange. And during that same time period, the state also made a number of organizational changes. The state restructured the Department of Health Services into DHCS and the Department of Public Health, transferred 750,000 children from Healthy Families to Medi-Cal, and then they also eliminated Mr. MIB. So there have been a huge array of changes made to these programs in recent years. During that period, from 07-08 to 14-15 fiscal years, due primarily to these changes, the overall funding, not just for kids, for DHCS has more than doubled after adjusting for inflation. This includes a 12% increase in general funds and a 137% increase in federal funds. However, overall funding for DPH has remained flat during that same period. General fund support for DPH programs decreased by 70%, while special fund support increased by 5%, and federal support has increased by 80%. And then recently, we've begun to see some modest investments in programs that support children's health. For example, during this past year, Policymakers restored state funding for Black Infant Health Program within DPH, and they also expanded Medi-Cal benefits for children with autism spectrum disorder through DHCS. So I'm not going to go into many of the other policy changes because Scott Graves, the Budget Center's Director of Research, is going to dive into some more of the details on potential investments during the current budget and legislative cycle in just a few minutes. So there are several actions that state policymakers could take to improve the health and well-being of children in California. And these are all recommendations that we include in our report. First, we would urge state policymakers to expand public health care coverage to income-eligible Californians that are currently not eligible based on immigration status. And we'd also recommend expanding outreach to ensure that all children and families currently eligible actually enroll in Medi-Cal. Second, we would urge policymakers to reverse Medi-Cal provider payment rate cuts. Medi-Cal provider network is already overextended, and low payment rates don't encourage providers to offer care to enrollees. One recent example of the effects of low provider rates is the report that came out from the California State Auditor this past December, which noted that low reimbursement rates for dentists is affecting children enrolled in Medi-Cal's access to dental care. Given that Medi-Cal provides public health care coverage to half of the children in the state, this is a huge problem. Third, we would encourage policymakers to assure quality of care for children with special health care needs. The state is currently convening a group of stakeholders to discuss the redesign of California's Children's Services Program, or commonly known as CCS. This is important because CCS provided specialty care to 227,000 children in the 12-13 fiscal year. So this is a huge group of children that this redesign could potentially affect. Fourth, we strongly urge policymakers to begin reinvesting in public health programs that were cut dramatically during the Great Recession, such as Children's Dental Disease Prevention Program, which could help address the problem that came up in the auditor's report, and then also California's teen pregnancy prevention programs, which were dramatically cut during the Great Recession as well. In addition, state policymakers could also expand some investments, improvement interventions like the nurse home visiting program, which is currently funded with just federal dollars. We know that investing in public health is an effective way to improve health and reduce healthcare costs, and this is a way to actually get upstream of health problems and address potential health issues before they become a problem. Yet funding for, as I just mentioned, funding for Department of Public Health remains flat. And finally, we urge federal policymakers to fix the family glitch. Currently, eligibility to purchase healthcare coverage through Covered California is based not on just family income, but also on whether or not families have access to affordable employee coverage. The glitch with the law, so to speak, is that the definition of affordability is based on the cost for an individual's healthcare plan, not a plan for the entire family, which we all know is going to be much more expensive and potentially unaffordable. So families affected by the glitch can't access insurance through the exchange using tax credits to reduce the cost. It's been determined that both the Obama administration or Congress could act to fix the family glitch, and we would encourage these federal policymakers to do so to make sure that children actually don't fall through the cracks and not get access to health care coverage. And at this point, I'm going to turn it over to Scott Graves, the Budget Center's Director of Research, who's going to discuss some more current policy opportunities.
Well, good morning. Chris, can you hear me?
Yes, I can hear you.
Great. Okay. So my task this morning is to provide a brief overview of some key opportunities this year to improve policies that address children's health. I'm going to focus on three major areas. The first one, and really the highest profile opportunity, is Senate Bill 4, which state senators just about a half hour ago passed on a bipartisan 28-11 vote. So that bill is moving on to the Assembly. SB 4 is a continuation of a year-long effort in the state legislature to expand public health care coverage to undocumented immigrants. The bill would make major strides toward achieving this goal, especially with respect to coverage for children through Medi-Cal, which is our state's Medicaid health coverage program for low-income residents. SB 4 would make children and youth automatically eligible for comprehensive or full-scope Medi-Cal coverage regardless of their immigration status, so long as they otherwise meet the program's requirements. Now, it's worth noting here that undocumented adults under SB 4 would be treated a little differently. They could also enroll in full-scope Medi-Cal, but only if the state identifies sufficient funding to pay for their coverage. But even if SB 4 is somewhat more limited now than originally envisioned, making undocumented children eligible for Medi-Cal would go a long way toward further reducing the number of Californians who lack health care coverage. Some estimates are suggesting that more than 200,000 undocumented immigrant children could enroll in Medi-Cal at full implementation if the provisions of SB 4 are enacted into law. So a second major area I want to focus on is the state budget, where lots of moving parts are in process right now. The deadline for passing the state budget bill is June 15th, less than 2 weeks away. The legislature, as many of you know, has convened a budget conference committee to iron out differences between the Assembly and Senate versions of the budget, even as they continue to negotiate behind closed doors with the governor on the outlines of the final budget package. So there are a few issues before the conference committee that would have an impact on children's health that I wanted to briefly highlight here. First, there's the Senate proposal to provide the dollars that would be needed to implement Medi-Cal coverage for children and youth as envisioned in SB 4. So this is another one of those areas in which a bill moving through the policy process has an interaction with what's going on with the construction of the state budget. In this case, the Senate plan includes $40 million to begin enrolling children, undocumented children in Medi-Cal in the coming fiscal year, which begins on July 1st. In this case, the Assembly and the governor have not addressed this issue. They have no proposal as of yet. Second, there's a proposal to roll back the 10% cut to Medi-Cal payments for doctors, dentists, and other providers, which took effect in 2013, and which advocates argue has discouraged providers from participating in Medi-Cal or accepting new patients, thereby creating some access issues in the program. The Assembly's version of the budget would fully phase out this cut over 2 years, starting next April. The Senate would end the rate cut for dentists only, and in the governor's view, we should just leave the current cut in place and monitor its impact. A third major budget issue is the proposal to reinstate the dental disease prevention program. This is one of those little programs that had a big impact. It was providing school-based dental health services to more than 300,000 kids each year until the state eliminated support for it back in 2009. So under the Assembly's version of the budget, they would provide about $3 million to restore that program, get it up and running again. The Senate and the governor have not addressed this issue, and that's why it's in conference committee. A third major area I'd like to focus on, finally, is the state's effort to renew its Section 1115 Medicaid waiver, under which much of California's Medi-Cal program currently operates. California submitted an ambitious proposal to the federal government for a new 5-year waiver this past March, which would take effect this coming November. I'm going to skip over the details here. It's very technical, but I did want to highlight the state's proposal to offer incentive payments to doctors and dentists to encourage them to accept more Medi-Cal patients or begin serving such patients. So while this program is not aimed at children specifically, it could help to increase children's access to health and dental care within Medi-Cal if the federal government provides the funding needed to make it happen. And that's a big if at this point, as state and federal negotiations will be continuing throughout the summer. So with that, I'll conclude my remarks and turn it back over to Chris.
Thanks, Scott, and thank you, Kristin, for your remarks. We got a few questions that have come in asking about the slides and when they'll be available. We'll be posting those on our website later this afternoon, along with related materials and the recording from this webinar. And so those will be made available. And as we proceed along here, please continue to ask questions and think about those questions you'd like to have addressed in the Q&A session, and we'll be cataloging those here as well. So it's now my pleasure to turn this over to Edward Schor with the Lucile Packard Foundation for Children's Health once again. Go ahead, Ed.
Thanks, Chris. Well, a number of the points that I'd like to make have been alluded to, but I want to just make some observations that may seem obvious but have some policy implications to them. First, you heard from Kristin, there are actually 33 state programs for children's health. That's a lot of programs. And it raises the question of how do they all fit together, or do they fit together? And I think, in my mind, there are opportunities to better integrate, at least coordinate among these programs than we currently see. This is some data from the Maternal and Child Health Bureau looking at the distribution of the state's budget for children with special needs and maternal and child health. What I think really stands out is, first of all, that California is ranked #1 in the country in terms of the proportion of that total budget that is directed toward direct health care services, and is second from the bottom in investing in infrastructure. My observations of California's public child health programs is that this virtual absence of infrastructure, whether that's for administrative support or other endeavors, is really holding us back from achieving some of the goals we'd like to achieve, and I think this needs to be investigated. Given the way the budget is laid out, and it's a scarce resource, we have an awful lot of people competing for those dollars. And since the services are not being coordinated well, this competition is actually hurting the delivery of services rather than streamlining the system. One factor that is, I think, affecting even the ability to better coordinate and integrate the child health care programs is the difficulty that exists in accessing data about these programs. This is cut and paste from the report that shows that the state was unable to provide data on Medi-Cal for the 2007-2008 period, or to report on those other categories, federal funds, state general funds, and so on, that were being used for Medi-Cal. If we don't have the data, you can't make informed decisions. I've just listed some of the key programs that are serving children in the state, but raise the question, do we even know which programs serve which children? My hunch is we have a huge overlap among these programs that we're not able to document because of the absence of data. That kind of overlap is likely to be leading to duplication and therefore lack of efficiencies in how we're spending our dollars. So the absence of data that I noted previously also plays out in the absence of data, not just where the funds are coming from and how much they are, but who is actually being served in each of these programs, and could we overlap some of these programs and save money and improve the quality of care. This is data directly from the report, and I think what you can see is that we seem to be increasing, in most cases, except for family planning access, the population served at the same time that we're decreasing the budgets. If that's truly the case, then you have to ask the question, how are we possibly providing good quality care or comprehensive care to the increasing population, let alone the existing population that's served by these programs? I think this is an important comparison chart and needs to be discussed. One area, obviously, in which we're being successful is we are enrolling more people, more children into these programs, particularly in what was the CHIP program, Healthy Families, and the Medicaid program. California is right about the average nationally for the percent of eligible children who are enrolled in these programs, but it means that we have 12% of eligible children, that does not include undocumented children, who are not yet enrolled in a program for which they are eligible. That should be a major emphasis, I think, of the departments to try to increase the enrollment of the eligible children. A point that was alluded to, and that is that just because you have an insurance card, a Medi-Cal card, doesn't mean that you have access to care. We have a substantial portion of California physicians who are not accepting Medi-Cal patients or accepting new Medi-Cal patients. I think it speaks to the professionalism and commitment of the state's physicians who do continue to see and enroll new Medi-Cal patients in their practices given the low reimbursement rate that they're having to deal with. So 2 points from this slide. When we had a recession, there were obviously extremely difficult and painful decisions to be made. The decisions almost always in those circumstances tend to focus on treatment rather than prevention. But that can have really adverse long-term consequences, particularly in the example of reducing prenatal services. That's going to cost a lot as we go forward. And secondly, when one looks at the rate of that's being paid by Medi-Cal to primary care providers as a proportion of what primary care providers in California are being paid by Medicare, you see that Medi-Cal pays 43% of what's being paid for Medicare, which is largely adult patients. It's the third lowest in the U.S. As a pediatrician, I'm not surprised by this. Children tend to get short shrift in all sorts of ways, but we're basically saying that children are worth 43% of what adults are worth in this state. I think that's a terrible statement to be making, and we really need to be investing much more strongly in children's health services if we want healthy, happy, well-functioning children today and a strong and vibrant labor force and state economy in the future. Thank you.
Thank you, Ed, and thank you for your comments and reflections on the report, as well as the deliberations about what the state invests or doesn't invest in children's health programs. Very timely given the conference committee's deliberations to set a budget for 2015-16 in terms of some of the issues we need to be addressing more actively as a state. Now I'm going to turn over to Timothy Brown with the School of Public Health, University of California, Berkeley, who's going to talk a bit more about options for policymakers and issues around county health departments, health status, etc. So Timothy, please take it away.
Thank you, Chris. Can you hear me okay?
Yes.
All right, great. So I'm going to talk about local health departments and how they improve health status and prevent death in California. And let's see if we get this to work. Okay, there we go. All right, one more back. Okay, so I'm going to talk about public health at the local level, some of the various things that county departments of public health do. I'll talk a bit about how prevention takes time. If you want to examine the effect of prevention, you have to look very carefully at the time lags. The causal connections are difficult to see. Oftentimes we're counting things that didn't happen. That's what prevention is all about. I'll show that investing in public health yields large returns, both in terms of improved general health status and in reduced mortality, as well as in the dollar values of those things. And then I'll talk about some opportunities for policymakers at the local, state, and federal levels. Let's look at some of the things that county departments of public health do in California. This is from 2010, and on the far right column you see the percent of departments providing each of these services. The things that are highlighted in green are things that are focused at children. Other things may also affect children, but these are the things that are focused on children. So you see the child immunization is done, blood lead testing is done, screening. A large amount of maternal and child health is done, very important for the state. We see that in terms of epidemiology and surveillance, they're trying to figure out what causes problems with maternal and child health. That's being done by most departments. We see that in terms of regulation, inspection, and licensing activities, we have public health involved in both schools and daycare and children's camps. And we see that public health departments are also involved in school-based clinics and school health to some extent. Now let's look at the more ideas about prevention takes time. Prevention will usually affect health status far earlier than it'll affect mortality. So it generally takes at least a decade before changes in health status will fully impact mortality rates. So any kind of model that's going to evaluate health status and mortality needs to take into account the fact that there are these lag times. If you don't take them into account, you will underestimate or even completely miss the effects on mortality and some other types of more longer-term health outcomes. If we look at the state spending, this is actually aggregate of county departments of public health in California, and on the bottom horizontal line you see the years 2001 to 2008. This is the most recent data that I had. On the vertical axis you see age-adjusted mortality per 10,000. This is all-cause mortality. And then you also see the dark line, inflation-adjusted per capita spending. And you can see there is a clear inverse relationship between spending and mortality, but there is a lag. From 2001 to 2003, you see spending going up, and you also see mortality being reduced. And even as spending starts to slow down and starts to be reduced, you still have this lag of mortality being reduced, and then it flattens out. Starting in 2005, 2006-07, you see an uptick in spending, but you don't see much happening with mortality. It doesn't start to kick in until a couple of years later, thus showing the lag. So these lags are very important in order to adequately evaluate programs. Let's look more carefully at these lags. If we look at the cumulative impact on all-cause mortality of a $10 per capita increase in public health expenditures in California, we can see how the lags will play out. On the vertical axis here, you see this is the change in all-cause mortality per 100,000, and then across the horizontal axis, this is the lags in years. So this is from a one-time increase in per capita spending. So in the initial year, you'll see about 2 3/4 lives per 100,000 are saved because of public health spending, but most of the effect happens in the years 2 through 8, actually goes all the way to 10. And if you stacked up all of these ensuing years, 2 through 10, they'd be far, far higher than the first year. So most of the impact actually is happening after the initial year of investment. So the overall results from models, and these are causal effects, not associations. We use very sophisticated statistical models to find causal effects. A model analyzing self-rated health, that's a 5-level health status measure, where 5 is excellent health, 4 would be very good health, 3 would be good health, 2 would be fair health, and 1 would be poor health. If you're moving from the poor and fair levels to good or above, the existence of California Departments of Public Health will result in about 200,000 people moving from this fair-poor category to good or above. And this is a causal effect, and that's from a single year of spending. And then over the next decade, about 27,000 of these people won't die, about 14%. And again, this is a causal effect. So again, with every round of funding in the County Departments of Public Health, about 200,000 people, 1/5 of a million people, will improve their health status, and of these 200,000 people, approximately 27,000 would not die who otherwise would have. This is a very large effect. What does it look like in terms of dollars? We can put a value on this move from fair, poor health to good, excellent health, and it ends up being about $42,000 per year. In terms of the valuation of an avoided death, that's set by the federal government at about $7.9 million. So in terms of the return on investment, every $1 invested in county departments of public health will return between $57 to $70 worth of improved health and avoided mortality. Very, very large return on investment. Now, let's do some cost comparisons to get an idea of where that fits in the distribution of how much it costs to save a life. So the cost per life saved, just looking at mortality, is about $110,000. Mammography, it costs about $100,000 per life saved. Higher nurse-to-patient ratios, which are now regulated in California, it costs between $136,000 to $450,000 per life saved. And mandated mental health insurance, which is a regulation in California and also federally, is about $1.3 million per life saved. So public health is at the bottom of this distribution. It's a pretty good value. Now, in view of all of that, what are some opportunities for policymakers, local policymakers, and many of you who are in public health already know this. you want to invest in proven public health programs. There's many sources of these. The Compendium of Proven Community-Based Prevention Programs, the Community Guide put together by the CDC, the Public Health Performance Improvement Toolkit, and the NACHO Toolbox. NACHO stands for the National Association of County and City Health Officials. These all provide tools and programs that have been proven to work. Opportunities for state policymakers. Ed kind of alluded to this. They need to invest in standardized data systems. For example, in Florida, county health departments have to report their expenditures in these various buckets, various categories. So it's relatively easy for an analyst to figure out how outcomes change when changes in these various expenditures in these various buckets change. Then, of course, you have to invest in data analysts. You can't do anything with data unless you have data analysts. And this is happening economy-wide. Firms in the private sector are investing in data analysis. UC Berkeley, in fact, is now proposing to require data analytics skills from all undergraduates. If you're an English major, you're going to have to learn how to do some data analysis. If you're a history major, you're going to have to learn how to do some data analysis. Everyone's going to have to learn how to do this. And then, of course, once you have your data and your data analyst, you have to invest in evaluation. For example, the Department of Mental Health in California spent a fair amount of money evaluating the Mental Health Services Act in California. This was something that was passed in 2004 and injected about 15% more money into the public mental health system, and the research on that yielded unequivocal results of the effectiveness in improving various outcomes for seriously mentally ill consumers. In terms of federal policymakers, the key thing you want to do is just invest in public health. On a practical level, demonstration grants to illustrate good public health practice would be really helpful. On the research side, grants for public health services and systems research to learn how to organize public health in a more efficient way would be very valuable. And then grants examining the returns from targeting various population groups, children, adults, older adults. They probably have somewhat different returns, and it helps to allocate the money if we have more information about this. Now here's some research, some articles that my work, what I presented is based on, and if you want to contact me, here's my contact information. Thank you very much. I'll turn it back over to Chris.
Thank you, Professor Brown. So we're now to the part of our program where we'll be taking questions from those of you that have been out there listening and being so patient. A couple have come in already, and so we'll start with those, but please type those in to the system there, and we'll continue to sort of funnel those through to the panelists. So I'm going to start with one question, which is that there's a big issue with children's health in terms of the redesign of the California Children's Services, or CCS. Could the panelists talk about that a little bit, including what you see as the keys to getting it right?
Chris, do you want any of us to take that?
Yes, actually, anybody who's willing, yeah.
Well, you know, a system that's right is one that meets the needs of the population that it's serving. So we need some data on what are the needs of the population, and we need to monitor whether or not those needs are being met. We really don't have any of that to be at this stage, so we really can't comment on the extent to which the current program is working, nor do we have in place the mechanisms to know if changes are made, whether that's an improvement or not. There's clearly, in the discussions that have been going on around the CCS redesign, there are clearly some things that people value highly, like access to pediatric subspecialists, and that's, I think everyone is generally agreed that is a core criteria for an effective system. Our foundation has published, and it's on our website, a document that lists the standards that a system of care for children with chronic health problems ought to be able to meet, and we're hoping people use that standard to help guide those discussions, and also then to monitor the effectiveness of a system. There's a lot of active discussion. UCLA, which is moderating the process, and the Department of healthcare services both have websites that have minutes of the meetings and discussions and summaries and so on that I think are open to anybody who wants to look at it.
Thank you, Ed. We have another question, I think directed to Professor Brown, but anybody who wants to respond is certainly welcome. And that has to do with what database changes have you suggested to assist county health departments to coordinate care of the multiple program users?
That's a great question. I haven't made any specific recommendations on that. I'd love to have the opportunity to do so.
Great. Another question here about a question that policymakers often pose is how we can tell in the short term that a program is meant to have long-term benefits and is actually working. The question has to do with how advocates and other stakeholders help address that disconnect between short-term realities and the policy-making process.
I personally would say that the main thing that advocates need to do is to emphasize that the expected outcomes of many programs don't take place right away. And if you want to find out if they're going to be valuable, you need to look at the long term. First Five, for example, has done a tremendous job at looking at the very long-term aspects of early childhood education.
And I think another thing that one could add to that is that we know that there are long-term benefits to public health interventions, for example. But I think another thing to think about is that it's just the right thing to do. It's the right thing to do to help kids learn how to take care of their teeth, or to work with at-risk families to teach them about how to care for their infants and mitigate potential abuse in the home, or to teach them how to be school ready. These are just things that benefit children right now, right here.
Yeah, I'd echo Kristin's comment. I think a lot of these things are the right thing to do, and we should be doing them. However, I appreciate the legislators and other policymakers' desire to have evidence of effectiveness, and would only caution that gathering that evidence has its own costs, and that has to be factored into the appropriations that are given for any program.
Great, thank you. Another question, state officials have asserted that there is no relation between provider rates and access to services. Can one of the panelists comment on this?
Yeah, I think that's nonsense. There's plenty of literature that supports the relationship between payment and access to care.
Ed is exactly right.
Yeah, the California State Auditor's report clearly indicates that it's the rates that is creating the problem with children not being able to access dental care. For example, Western Dental, one of the state's largest providers of care through Medi-Cal, is actually pulling out, and they're citing low reimbursement rates because of it.
Let me also add, though, that where rates, although rates are important, the literature suggests that there are other things that will encourage and enable practitioners to care for children even when they're not getting what they feel is an adequate reimbursement. But if you look at back at the slide that I showed you on the infrastructure support, the kinds of supports that practitioners would like to have, whether that's help getting data systems or electronic medical records in place, whether it's technical assistance on improving the performance of their practices, whether it's facilitating communication among healthcare systems and so on. There's a whole litany of supports that could be offered that would encourage practitioners to take relatively low-paying patients, and yet the state has such a low infrastructure budget that it's not prepared to provide those kind of supports any more than it's prepared to provide a reasonable reimbursement for care.
Can one of you comment on the influx of federal funding from the CHIP bump, the increase in reimbursement funding from the federal government for the children's health insurance programs, and what that funding will be used for? Have you been able to get a clearer sense of what the dollars will be directed towards?
Hi, this is Scott. I'll go ahead and take that one. So just some background for folks who may not be familiar with this issue. Earlier this year, the federal government reauthorized the Children's Health Insurance Program, which provides a substantial funding stream that California uses to provide health care coverage for many children enrolled in the Medi-Cal program, not all kids, but hundreds of thousands of them. And as part of that change, Congress also allowed to go forward a significant increase to the federal government's share of cost for so-called CHIP-related expenditures. So whereas before the federal government was paying about 2/3 of California's CHIP-related costs, they increased their sharing ratio, as it's called, to 88%. So that means the feds are paying almost 90% of California's CHIP-related costs for children in the Medi-Cal program. California is paying 10%, whereas before we were paying about 1/3. So as a result of that, over at least the next couple of years, California will see substantial savings in its state budget simply because it can maintain the same level of services to these children enrolled in Medi-Cal, but use fewer state dollars for that purpose, essentially freeing up state general fund dollars within the budget. Now, while this was happening, there were many advocacy organizations, including the California Budget and Policy Center, that were suggesting that the governor should consider ways to capture those dollars and reinvest them for various purposes. Some groups were urging that the dollars be used solely for children's health. We were taking a bit of a broader perspective, arguing that the dollars could be used for a number of worthy purposes. Many programs are still operating at recession-era levels. What actually happened when the governor released his May revision last month was that the dollars were essentially absorbed back into the Medi-Cal budget. So the governor didn't necessarily designate those dollars for any particular purpose. As with any revision to the governor's budget, there will be some increased expenditures relative to what he proposed in January. There will be some reduced expenditures relative to January. And sort of the way that all netted out was that the dollars were sort of absorbed back into the budget. Now, one thing we would note, though, is that the governor, as many of you know, has made a very good proposal to create a state earned income tax credit. Now, the amount of state dollars freed up by the so-called federal CHIP bump was estimated by the governor to be $381 million. It just so happens that the first year's cost of the governor's state EITC proposal is about $381 million. So you could sort of make an argument that the governor sort of unintentionally or not created a state EITC for which expenditures are paid for, at least in the first year, with the savings that were generated by the increased federal funding for CHIP expenditures in California. Now, there's no way to definitively trace the dollars because what the administration has argued is sort of the first explanation I gave you, which was that the dollars were simply absorbed back into the Medi-Cal budget to offset higher than expected costs. So really, this is one of those budget mysteries for which there will never be a definitive answer, but the way it's worked out is certainly disappointing to many advocates.
Thank you, Scott. We have a question. Can someone summarize the perception of support and dissent for the SB4 application to the undocumented population?
I'm not sure I understand that question.
I think just wanting a sort of a summary of sort of where the support and dissent arguments are, but I don't have more information than that.
Yeah. Well, I mean, I've been following SB4, but you know, the arguments the arguments against providing health care coverage to undocumented immigrants in California are typically not aired very publicly because you know, they're difficult arguments for those on the other side to make. I think the interesting thing to point out is that in the vote on the Senate floor this morning, 28 senators voted to move SB 4 off the floor and over to the Assembly. And among those 28 votes were 2 Republican senators, Senator Cannella and Senator Vidak. So I think it's clear that advocates with their arguments in favor of providing health care coverage for all of the remaining uninsured in California, despite the advances of federal health care reform, really had a significant impact on many senators, including those on the Republican side who you might typically expect to vote against such a proposal. So clearly the arguments of advocates for SB 4 carried the day in the Senate.
Great, thanks, Scott. We're going to try to fit at least one more question in here. The department has increasingly pushed responsibility for ensuring provider access onto managed care plans. To what extent is this going to inhibit advocates' ability to press for greater government accountability for healthcare access?
It depends. There's a hierarchical anxiety that's at play here. State Medicaid programs want managed care companies to take on responsibility for these patients. They have to make it sufficiently attractive to them for them to contract with the state to do that. And the managed care companies want to be able to contract with providers and don't want to squeeze too hard on them so that they can have an adequate panel. So there's kind of a disincentive in the system for holding people accountable or pressuring them to do more or better. That's going to take advocacy oversight, the provision of good data, and constant attention and commitment from all parties who want to make sure that they do the right thing for these kids. But it's going to take a constant, long-term process to make sure that happens.
Great, thanks, Ed. Got one question, I think time for one more question here about children with rare disorders. The question says that these children need access to specialists, yet Medi-Cal managed care plans now have authority to determine medical necessity for all beneficiaries, despite Medi-Cal managed health plans' lack of sufficient volume of rare disorder beneficiaries. And the question then is how to address this issue.
I think that's a really thorny question. And it depends on what position the state wants to take in its contracting for services with managed care, and if there are additional ways of funding the care of those kids outside of managed care that the state wants to continue. It's a difficult one, it's solvable, but it's going to take some creativity.
Great, thank you, Ed. So I think that brings us to the close of the webinar here. Just a few more housekeeping notes. I want to remind everyone that we'll be posting the recording and the slides on our website later today. Thank you all for listening in. We'll be sending out a brief evaluation this afternoon and would greatly appreciate your sharing your thoughts about the webinar and how we can improve our offerings like this down the road. And a reminder to visit our website at calbudgetcenter.org and to follow us on Twitter at CalBudgetCenter. And thank you once again to our panelists, to Kristin Schumacher, Scott Graves, Edward Schor, and Timothy Brown, and particularly to the Lucile Packard Foundation for Children's Health for supporting this work. Thank you, everyone, and have a great day.